Hello and welcome to another chapter in the Respiratory Medicine module, Cystic Fibrosis. By the end of this module, you should be able to define cystic fibrosis, outline the etiology and pathogenesis of cystic fibrosis, summarize the clinical manifestations and steps to how a diagnosis of cystic fibrosis is established. You should also be able to formulate a management plan, outline the complications and prognosis of cystic fibrosis. Let's get started. What is cystic fibrosis? Cystic fibrosis is a genetic disorder caused by an autosomal recessive defect associated with the CFTR gene, or also known as the cystic fibrosis transmembrane conductance regulator gene. The defect disrupts the function of the chloride channel, resulting in production of sticky secretions by the exocrine glands. The body parts that are most affected include the epithelia of the respiratory tracts, the biliary tracts, the pancreatic duct, the small intestine, the deferent duct, and the perspiratory glands. This is an example of an autosomal recessive inheritance, which is seen in the inheritance of the mutated gene in cystic fibrosis. If both parents are carriers, only 25% of the time the child will be affected. There are several types of mutation, and this can be classified into four: the absence of CFTR gene expression, synthesis of CFTR channel but without membrane incorporation, defective channel expression and incorporation without opening due to the mutation, and lastly, the incorrect protein folding resulting in defective channel opening. As a result of the genetic defect, the chloride channel loses its ability to release chloride and bicarbonate ions from the cell. The increased sodium absorption leads to the formation and accumulation of tough bronchial mucus in the lungs, causing mucostasis due to the lack of osmotic water absorption from the tissue. The resulting obstipation and inflammation eventually leads to complete organ destruction and functional deficiency. Clinical manifestations of cystic fibrosis can be easily remembered with the mnemonic CF pancreas. C for chronic cough. Thick secretions result in recurring bouts of bronchitis and pneumonia. Bacterial infection, for example, Pseudomonas aeruginosa and Staphylococcus aureus. F for failure to thrive. Due to the lack of digestive enzymes, the body is deprived of macro and micronutrients that are absorbed with food. Malabsorption in turn leads to failure to thrive, despite the increased energy demand. P is for pancreatic insufficiency. The blockage of the exocrine secretion outlets, fibrotic and cystic mutations leads to the loss of exocrine function. A for alkalosis and hypotonic dehydration. N for nasal polyps and neonatal dehydration. C for clubbing of fingers. R for rectal prolapse. E for electrolyte elevation. A for atresia and absence of vas deferens. And lastly, S for sputum associated with cephalococcal and Pseudomonas infection. The diagnosis is made by detection of abnormally high sweat chloride, which is more than 60 millimoles per liter, by doing a sweat test. This test is considered gold standard of diagnosis. Genetic analysis is another way of making diagnosis. This procedure is indicated for siblings of index patients and those diagnosed with cystic fibrosis, contemplating pregnancy and childbirth. Neonatal screening for cystic fibrosis is now performed via Guthrie's heel prick test in newborn babies. Once diagnosed, this condition requires multimodal treatment where possible. This table summarizes the management for the problems faced in this condition. Let's go through them individually. For the exocrine pancreatic insufficiency, administration of pancreatic enzymes with every meal is required. Vitamin deficiencies can be treated with high doses of lipid-soluble substitution. For diabetes, therapy to reduce blood sugar levels with oral diabetic agents or insulin can be advocated. Respiratory tract infections can be treated with chest physiotherapy, postural drainage, bronchodilator therapy, mucolytics, vaccination, antibiotic therapy, and lastly pneumonectomy or lung transplant if indicated. For liver cirrhosis, you can consider portosystemic shunts or urodeoxycholic acid with taurine. Complications of cystic fibrosis. Frequent lung infections due to blockage of mucociliary clearance. Cor pulmonale due to pulmonary hypertension following chronic lung inflammation. Indigestion leading to obstipation. Endocrine pancreatic insufficiency secondary to blockage of the exocrine secretion outlets. Biliary cirrhosis due to obstruction of bile drainage, and spontaneous pneumothorax due to chronic inflammation leading to the loss of elasticity and recoil capacity of alveoli. Patients diagnosed with cystic fibrosis live to an age of 30 to 40 years when treated optimally, although 50% of patients die before age of 18 from respiratory failure. The prognosis depends on several factors, which are time of diagnosis, population of resistant pathogens, lung function, complications, and pregnancy. Women suffering from cystic fibrosis are fertile in contrast to men. The CFTR allele is passed on from the mother to the fetus. The child is therefore at a 1 to 50 risk of falling ill with cystic fibrosis. Now, let's summarize. Cystic fibrosis is a multi-system disorder which is characterized by the disruption of chloride channel leading to mucostasis and multi-organ dysfunction. It is an autosomal recessive inherited disorder whereby the defect is identified on the CFTR gene. Clinical manifestations range from failure to thrive up to infertility in males because almost every duct in the body which carries secretion are affected. Diagnosis is made by doing a sweat chloride test. The goals of management in cystic fibrosis is to restore the function of the organs, promote healthy growth, replenish electrolyte and fluid deficits, reduce the progression of the complications. We have come to the end of this module. Thank you.